I want to talk today about instant restenosis. I strongly suggest that you review my prior talk on instant restenosis, where I detail the various mechanisms, therapies, and algorithm with data and numbers. I will summarize those today and show some practical complex cases. First, whenever we have instant disease, you need to define the mechanism by using IVUS or OCT and stent boost STEMI. And you will define the mechanism into one of the following two: stent underexpansion or tissue growth. Usually it's a stent underexpansion in 40+% of the cases, and tissue growth in about 60% of the cases, with a lot of overlap in over 20% of the cases. If it is stent underexpansion, the big treatment is either lithotripsy or laser atherectomy after having tried high pressure balloons. If it is tissue growth, it's usually either neo-intimal hyperplasia, usually in the first 1 to 3 years, or neo-atherosclerosis after the first 1 to 3 years. But regardless, we manage those two mechanisms similarly. And tissue growth implies you have tissue on the inside of the stent occupying more than 50% of the stent area. And tissue growth is treated grossly by one of the following two: restenting or drug-coated balloon. Restenting is an option if you only have one stent layer with restenosis. Drug-coated balloon is an option if you have one or two stent layers. Other options are brachytherapy, especially if you have two stent layers. Rotational atherectomy or lasers are not good therapy for the tissue growth itself. They do not reduce the chance of restenosis. However, they may be used in this setting if you have a lesion, instant restenosis, that is uncrossable with your balloon. You may use rota or laser. Or if you have a heavily calcified neoatherosclerosis that may or may not be crossable, but that's not going to yield well with balloon or get a good result with balloon. So you may use rota or laser not to reduce restenosis, but to improve your acute result in calcified neoatherosclerosis, as I will show, or if you cannot cross the lesion with a balloon. And most algorithm you will see in review papers focus on those two. They omit the third important mechanism, especially in MI setting. Beside underexpansion and tissue growth, think, do I have a stent thrombosis? If you have a stent thrombosis with mild tissue growth, less than 50% in stent tissue growth, then in that case, do not restent. All you need to do is just balloon and improve your stent expansion. Those would be cases where you have instant thrombosis related to either underexpansion or pharmacology. Now, you may have stent thrombosis on top of significant tissue growth, like neoatherosclerosis with neoatheroma plaque rupture or severe neo-intimal hyperplasia. So in that case, you will need to not just balloon, but you will need to treat it as significant tissue growth using restenting or drug-coated balloon beside optimization with potentially high-pressure balloon to improve stent expansion. And keep in mind that when you have an MI related to a stent process, it could be pure instant restenosis without thrombus, or it could be pure thrombosis, or frequently coexistence of both. Instant restenosis by itself or progressive instant neoatherosclerosis may lead to non-STEMI in 10 to 20% of the cases. And it may lead to STEMI if there is a superimposed thrombus. Now, how do we define stent underexpansion? It is best defined by IVUS or OCT as a stent area that is less than 90% of the distal reference lumen area, the blue arrow here, less than 90% of that. You have an area here that is less than 90% of the area of the lumen here, or less than 80% of the average proximal and distal reference lumen areas. And if you have long stented area across a bifurcation or across a long vessel taper, then you can define a proximal underexpansion as less than 90% of the proximal reference and distal underexpansion as less than 90% of the distal reference. Or if you want to be conservative, less than 80% of those reference lumen areas. Also, it's a stent that is less than the intended nominal stent size. So if you have a 3 millimeter stent, it has to reach the area of a 3 millimeter stent, 7.1 millimeter square. Another way of defining stent underexpansion that was used in the major IVUS trials, Ultimate and Renovate complex PCI, is using absolute rather than relative stent area values. A stent area that is less than 7 millimeter square for the distal left main, or 8 millimeter square for the proximal left main, or less than 5.5 millimeter square for any of the other major vessels define underexpansion. Those trials defined underexpansion using either or. They did not mandate that the stent needs to be well expanded by both criteria. However, I prefer to fulfill the relative criterion, but it's important also to know both criteria. Sometimes, even if you don't fulfill that 80-90% reference lumen area, but your stent is over 5.5 millimeter square, you have an acceptable result. But I prefer to fulfill both criteria. Keep in mind also for the left main, even though those are the values used in those trials, European data suggests over 11 millimeter square in the left main is the number associated with the best long-term outcomes. Now, when we have instant restenosis from tissue growth occupying over 50% on the inside of the stent, how do we treat that? The two big modalities are sandwich DES, meaning putting another stent inside that stent, or DCB. Sandwich DES is associated with about 15% risk of recurrent restenosis at 1 to 2 years versus DCB 20% at 1 to 2 years. Those numbers being worse if you have diffuse instant restenosis occupying the whole stent or extending to the edges of the stent, and even more so if you have occlusive instant restenosis. It goes up to 25-30% in those cases. And which one do you choose? Both repeat DS or DCB are options for DS restenosis. DCB should be strongly considered for focal instant restenosis, including isolated focal edge instant restenosis, keeping in mind that most DS restenosis are luckily focal. 2/3 of them are focal, so they would do very well with DCB. Repeat DS or sandwich DS should be considered for recoil or neo-atheroma dissection after ballooning. Basically, you balloon that instant restenosis, the balloon yields, but you get either significant residual stenosis or you get dissection of the neoatheroma inside the stent. So basically, you get a poor balloon result. Those cases, the ultimate treatment cannot be DCB. You have to put DAS. Also, DAS should be considered for a heavily calcified neoatherosclerosis, where again, you're not going to get a good balloon result. You will get dissection of the neoatherosclerosis, or you will get recoil. Also, it may be considered possibly for diffuse instant restenosis, where the long-term restenosis rate is generally higher. But especially should be considered for poor balloon result or for heavily calcified neoatherosclerosis. Now, what is the role of rotational atherectomy in instant restenosis? As I mentioned, rotational atherectomy is mainly used for stent underexpansion that doesn't yield with lithotripsy or laser. The other case where it's used is instant tissue growth that is heavily calcified or that cannot be crossed with a balloon. you consider in those cases laser or rotational atherectomy. And beware of the burr getting stuck when you use rotational atherectomy in underexpanded stent. I'm not usually worried when it is a calcified neoatherosclerosis for which I'm using rotational atherectomy, but I'm more worried when the stent is underexpanded. Orbital atherectomy has been described in those cases, but I favor it less because it has an inherently higher risk of burr getting stuck in an underexpanded stent, as the orbital burr orbitates eccentrically. Laser atherectomy does not reduce long-term in-stent tissue growth. A lot of people use it for reducing in-stent tissue growth. It has been proven to do that in SFA, in the periphery, SFA restenosis, but not in coronary in-stent restenosis. So laser is valuable for stent underexpansion, and you may use laser with contrast to create vaporization of the lesion behind the stent and allow better stent expansion. You may also use it for balloon uncrossable or balloon unexpandable in-stent restenosis, such as calcified neoatheroma, as a preparation for DCB or repeat DES, not as a standalone therapy. Cutting balloon or scoring balloon like angiosculpt may be used to disrupt the neointimal hyperplasia or the neoatheroma before DCB or repeat DES. It allows better DCB results. It's particularly valuable before DCB because it allows better lumen gain with balloons, so better balloon result in general, so that you can treat the lesion with DCB and not have to stent. It also allows potentially better DCB drug delivery, especially in calcified neoatherosclerosis. And ISR Desire 4 has shown that scoring balloon improve the antistenotic efficacy of DCB therapy with lower long-term late lumen loss. As a summary to the approach for in-stent disease, I would say that whenever you have an in-stent process, you always ask yourself, what is the mechanism? And you define that by IVUS or OCT and cine-stent boost. Then you ask yourself two questions. What is the ultimate treatment after lesion preparation? Should it be DCB versus repeat DES if you have in-stent tissue growth more than 50%? DCB is reasonable if the neoatheroma does not recoil or dissect with a standard balloon. In a calcified neointima, DCB is unlikely to be enough. You get recoil, dissections inside the neointima, then DES is your better option. If you have a pure stent under expansion, then you don't need neither. You just need to improve the stent expansion using high pressure balloon or laser and lithotripsy, or occasionally in refractory cases, rotational atherectomy. If you have a pure stent thrombosis with mild tissue growth, do not restent as well. Just improve stent expansion and balloon. So you notice that in pure stent thrombosis or predominant stent thrombosis and in predominant stent under expansion, you do not need to restent and you do not need DCB. The DCB and restenting are for major tissue growth, which can at times be associated with stent under expansion or stent thrombosis. So that's the only category that needs a stent and DCB. So the first question is ultimate treatment after lesion prep. But the second question you ask yourself, how do I prep the lesion before the ultimate treatment? In underexpansion or calcified neoatherosclerosis or unyielding neoatherosclerosis, you need any of the following three: high pressure balloon, cutting balloon, then if needed, lithotripsy balloon. Then if lithotripsy fails or the balloon cannot be advanced, you need to consider rota and or laser. I will show some cases here. This is a 67-year-old man who had RCA stent 15 years previously. He still smokes and has diabetes. He presents with inferior STEMI. And this is his RCA angiogram. This is the stent and it's occluded. What is the mechanism statistically of the stent occlusion? This patient had a stent 15 years previously. The mechanism is most likely tissue growth inside the stent, neo-atherosclerosis, particularly beyond 1 to 3 years of DES, so neo-atherosclerosis, with plaque rupture of that and thrombus formation. So statistically speaking, this is most likely neo-atherosclerosis with a plaque rupture and thrombus formation. So here is what we did. We wired the lesion, we ballooned it with a 3 millimeter balloon. It was difficult to yield initially. We had to go up to 23 atmosphere to make it yield. Then we did IVUS after balloon. And this is what we see on IVUS. We see that he has a stent. Those are the stent struts. And we see that he has a calcified neoatheroma inside the stent. This is neoatheroma. Part of it is soft and part of it is calcified. This is another view. This is a stent. This is neoatheroma, and this is a calcified neoatheroma here. Okay? And at another portion of the stent, you see really the biggest problem. This is a stent here, those bright white ones, those are the stent struts. This is neoatheroma inside it. And what you see here, this is calcium inside the stent. And you see actually a calcified nodules inside the stent. This is calcified neoatherosclerosis with a calcified nodule, likely an eruptive calcified nodule that caused the thrombus formation inside the stent. And this is the IVUS run distally to proximally. So you can see the stent struts. Not much neoatheroma here distally. And now you start seeing the neoatheroma. You're starting to see neoatheroma here. Then you see calcium inside that neoatheroma. Here you see neoatheroma without calcium. Then here you see a big piece of calcium. Inside the stent, you see a big piece of calcium protruding in the lumen. And that's the calcified nodule of that calcified neoatheroma. And that's what caused the patient's ACS. So after defining the mechanism of MI in this patient, then we have to ask ourselves how to treat it. So this is a stent thrombosis on top of heavy neoatherosclerosis, calcified neoatherosclerosis. The eventual treatment will be DCB versus re-DES. In this patient with heavily calcified neoatheroma, DCB is unlikely to be enough. So I'm already planning, even though it is a stent thrombosis, and I don't like usually to put another stent if it is an isolated stent thrombosis. In this case, I have to put another stent. It's not an isolated stent thrombosis. It's heavy neoatheroma underlying the stent thrombosis. So I will put a DES. If it wasn't heavily calcified and I thought I could get a good DCB and balloon result, I would stop at DCB. But I think here I will need a repeat DES. Now, how do I prep that lesion before the ultimate treatment? In a calcified neoatherosclerosis, I will try high pressure balloon and cutting balloon. If that doesn't work, lithotripsy. If that doesn't work, I will consider rota and or laser. In this case, what I did, the lesion didn't yield well with a 3 millimeter high pressure balloon, 23 atmosphere, but it yielded well with a 3.5 by 10 millimeter cutting balloon. But there was recoil. I didn't get a good balloon result, which is what I expected. The lesion yielded, however, which told me that if I put a DES, I should have a good result. So that's what I did. I eventually stented the lesion and I placed a DES with a very good result. Note that the patient also had a lot of distal emboli, some in the PDA, some of the PLB. I did daughtering to the PDA thrombus as well as to the PLB thrombus. You can do low pressure balloon dilatation. Try not to stent so distally, as the runoff is not large, and you may end up with a stent thrombosis if you put a stent distally without much runoff. Focus on doing lesion daughtering, maybe a small balloon inflation, and potentially 2B3A inhibitors. And those are images from the literature showing you that calcified neoatherosclerosis. So here you see stent struts, those white dots, and this is calcified neoatheroma that they highlighted in gray here. This is calcified neoatheroma. This is a study that shows the prevalence of neoatherosclerosis in patients with instant restenosis versus the prevalence of neointimal hyperplasia. Now, both of those are managed similarly. They are both instant tissue growth. They have different mechanism, and neoatherosclerosis is important because you can get calcified neoatherosclerosis that is difficult to yield. You can also get plaque rupture in that neoatherosclerosis that causes those late MI and stent thrombosis inside the stent. You can see that neoatherosclerosis becomes very prevalent after 3 to 5 years, especially after 7 years. Any tissue growth after 7 years is essentially neoatherosclerosis, not neointimal hyperplasia. And you can see the high prevalence of calcification inside it. The gray here, over 7 years, 55% of neoatherosclerosis is calcified. And those are images from the literature of calcified neoatherosclerosis. This dark, well-demarcated area on OCT is the calcium. It's inside the stent. This is the stent here, and the calcium is inside the stent. The rest of it, the bright yellow here, this is non-calcified neoatheroma. This is another image here. This is the neoatheroma, the yellow. This is the calcified portion of the neoatheroma. This is another case where, again, you see neoatheroma as the bright yellow, and deep inside, you see that calcified neoatheroma inside the stent. Large area here, close to 180 degree, and here more than 180 degree of calcified neoatheroma. Again, this is calcified neoatheroma. This is a case where you have inside the stent neoatheroma, the bright yellow. You also have deep inside the stent, you have that calcification, that dark area that is highlighted here in the white. So you have calcified neoatheroma, you see it here. But importantly, you see also calcium behind the stent. So this is calcified neoatherosclerosis inside the stent struts that's connected to calcium outside the stent struts in the original atheroma. This is calcified neoatherosclerosis as an extent of the persistent calcium behind the stent struts. Maybe the persistent calcium is penetrating into the neointima. That could be one mechanism of calcified neoatherosclerosis, although it's not well established. And those are images of calcified nodule inside the stent. So those are stent struts here. You see them highlighted, stent struts. And inside it, you see that dark, well-demarcated area that is protruding in the lumen. This is calcified nodule inside the stent. Calcified nodule inside the stent. Here again. Here again. And here I want to explain what is calcified nodule, whether inside the neoatheroma, inside the stent, or in your standard native atheroma. A calcified nodule is an eccentric, protruding piece of calcium. The key word in defining calcified nodule is protruding. So meaning that piece of calcium protrudes, bulges in the lumen. That's a calcified nodule. Now, calcified nodule can be eruptive or non-eruptive. Eruptive calcified nodules mean that calcified nodule not only protrudes in the lumen, it ruptures the cap above it and frequently causes thrombus formation and ACS. So this here, for example, is a non-eruptive calcified nodule. You have a calcified nodule, it's a protruding in the lumen, but the cap is intact, is not ruptured. Here, on the other hand, this is an eruptive calcified nodule that has ruptured the cap here and here and here. You see there is no cap here. It ruptured the cap. So an eruptive calcified nodule often causes thrombus formation and ACS. Why are those nodules important? One, they are important because they can cause ACS. Two, they are difficult to expand. And they are difficult to treat, maybe even more difficult to treat than the concentric calcium. Why? Because since the calcified nodule is eccentric, rotational atherectomy may not affect it. It may rotate away from it unless the rotational atherectomy wire is hugging that calcium. It has a wire bias that is touching the calcium. Otherwise, rotational atherectomy will not be effective in cutting it, which will cause stent underexpansion. IVL is the best strategy for resilient calcified nodule. Orbital atherectomy may be used, and it is more likely to orbitate eccentrically and touch the nodule, but it's also potentially more likely to dissect or perforate the non-calcified part of the vessel. This is another case. This is a patient with prior cabbage and patent lima to LAD. The problem is the impaired native flow into the diagonal that's causing him to have angina. He has severe restenosis inside 2 layers of stent in the proximal LAD leading up to that diagonal, and he has severe stenosis of the diagonal ostial area. So we want to treat that whole area. And in such a complex case with 2 layers of stent, we need to define the mechanism. So it's important to do IVUS. After some ballooning, it may be difficult to do IVUS in such tight disease, so you may need to advance a 2 millimeter balloon, dilate the area before you can get your IVUS catheter. So that's what we did here. And this is the ostium of the diagonal. You can see that there is calcium, nearly 180 degree of heavy calcium in the diagonal. Now, the more difficult part is the LAD. And look at this run of the IVUS here. And you can see here already that there are stent layers. Those are the stent layers here. And inside the stent, this here, those are the 2 stent layers. You see the 2 stent layers opposed. And inside that, you see a soft neoatheroma and calcium specks. You see calcium in that neoatheroma at the surface of it. So you're already seeing calcified neoatherosclerosis. This is further up in the stent, and here you can see neoatheroma without much calcium. You see the 2 stent struts well opposed. The issue is inside it, neoatheroma. You keep running, and here you see heavily calcified neoatheroma. This here is heavy calcium. Now, one may say, well, maybe this is one stent and this is the other stent because we have 2 stent layers. That could be the case, and as we do more and more of those complex patients with multiple layers of stent, it may be difficult to distinguish a second stent layer from calcified neoatheroma. But the run and how things are changing between frames help you make the case for calcium or not. But those are difficult cases. Again, here I see the 2 stent layers, so this must be calcium inside the neointima. And actually, you see neointima here. You see neointima here. So this is neointima, neoatherosclerosis, and this is calcium inside that neoatheroma, actually. Again, neoatheroma, and this is calcium in the neoatheroma. And here it's an area where the stents are well seen without much neoatheroma. And this is an explanation using select frames. So these are the stents here. You see them? Then inside them, you see that neoatheroma. And on top of the neoatheroma, you see those white specks of calcium. So neoatheroma here, specks of calcium, calcified neoatheroma. This is more proximally in the stent. Again, you see the stents here, 2 stent layers. You may not see the two stent layers over the whole circumference, but we're seeing them in some places. Inside them, you see neoatheroma, soft portion, and calcified portion. Again, here one may think this is not calcified neoatheroma. This is an underexpanded inner stent layer. Like this is one stent, this is the other stent. But it's more like a calcified neoatheroma. The run helps you say that. Also, the fact that you see two stent layers well expanded, and the run helps you define that this is neoatheroma and this is calcium inside that neoatheroma. Regardless, for treatment, even if this was an underexpanded inner layer of stent, for treatment, it's kind of the same. We have to use heavy either calcium or stent modification here. So you may need to do rotablation or laser regardless. This is another frame here that further confirms that what we're seeing is calcified neoatheroma. So you see neoatheroma here, and around the same level, in contiguity with that neoatheroma that is soft here, you become calcified here. And you're calcified there. So you have about 180-degree arc of calcified neoatheroma. This is an area where you also clearly see the two stents. You see the old atheroma, the original native atheroma behind the stents, I indicated by the rectangle here. You see the neoatheroma inside the stents, marked by the star, and inside that neoatheroma, you see a piece of calcium. So basically what we have here, we have a heavily calcified diagonal stenosis, and we have a heavily calcified neoatherosclerosis of the LAD. The best treatment here is rotational atherectomy, 1.5 millimeter burr, for both the calcified neoatheroma of the LAD stent and for the native diagonal calcified disease. So that's the answer to the first question, how to prep the lesion. The second question, how to ultimately treat that lesion. After we prep it with rotational atherectomy, we can do DCB, but since it's neoatherosclerosis that is heavily calcified, I doubt DCB will give us a good result. So after rotational atherectomy, what we need to do for the LAD, DCB, if we can get a good balloon result, but that's doubtful considering that we have calcified neoatheroma. Now for the diagonal, which is native disease, not instant disease, I would do DES after rotational atherectomy. So here what we eventually did, we did rotational atherectomy and we placed the stent from the LAD into the diagonal. And you can see here the rotational atherectomy inside the stent of the calcified neoatherosclerosis. And see how we do it. When you do rotational atherectomy inside the stent, be slow and careful. Try not to penetrate the whole stenotic area in one or two throws. Do it progressively over multiple passes. And you can see here, we progressively penetrate the lesion. With each pass, a little more. We do 10-second runs, slow forward packing, slow penetrating of the lesion. Eventually, we fully penetrated the lesion after 5 passes on purpose. I don't want to cross it quickly. And we pack slowly, 10 seconds at a time. This way, we limit the risk of the burr getting stuck and the risk of perforation. And you can see here, around the 5th or 6th pass, we're starting to pack more at the lesion. Then here at the 6th pass, we crossed it. So brief, slow packing, 5-6 passes before I fully penetrate the stent. Then we eventually stented from the LAD to the diagonal with very good result. This is another case. This is a 58-year-old man with extensive renal history prior to renal transplant. Currently has CKD stage 4 of his kidney transplant. He also has systolic heart failure with an EF of 30 to 35%. He has multiple prior stenting, and he's coming with restenosis of the left circumflex and severe angina. And this is his angiogram. You can see the severe disease in that circumflex and patent stents from the left main into the proximal LAD. And here I will explain to you how many layers he has. So he has one layer of stent in the left main in 2024, two layers of stent in the LAD 2018 and 2024. Both those are patent. He has one layer of stent in the left circumflex, the one that is restenosed. It's from 2009. And he has another layer in the left circumflex, a bit more distally. From 2024, this layer looks angiographically to be underexpanded. So the circumflex has one layer, two stents, but one layer. Ostially, it seems to be instant tissue growth, at least angiographically. And a little more distally here, it seems to be underexpansion, but one layer. So the process, if we have to guess before IVUS, just using our Cine boost, this is likely neoatherosclerosis, as the stent seems well expanded by fluoro. Also, it's a stent that is from 2009. It's hard to imagine a severely underexpanded stent for so long not causing issues. So this is likely here neoatherosclerosis. It's unlikely neointimal hyperplasia, again, 15 years later, although, again, the treatment may be the same, except that neoatherosclerosis can have a lot more calcium than neointimal hyperplasia, which is an earlier, rather fibrotic process. The process for the more distal stent, one layer of stent, the process is underexpansion by Cine. And here you can see by Cine boost, the first stent here in the circ is well expanded. The process is likely neoatherosclerosis. That other stent is underexpanded, and you can see here using a 2.5 millimeter balloon that it's clearly not yielding. So we defined our mechanism by Cine. We also defined our mechanism by IVUS. In order to be able to IVUS the lesion, we have to balloon it to be able to pass the IVUS catheter. And here we did some 2.5 millimeter balloon pre-dilatation before doing the IVUS. And we did the IVUS. The IVUS confirmed my suspicion. So in that area, what you see, old stent struts, and inside it, you see really heavy calcium. All this is calcium. This is here neoatheroma. This neoatheroma. This is a stent strut. This is a stent strut. Imagine this is a stent. This is neoatheroma here. And this is calcified neoatheroma. So 180 degree of calcified neoatheroma. This is another frame showing the same. These are the stent struts. Again, you may not see the full circumference of stent struts. You will see few of them. I see stent strut here, 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 and here. And inside that stent strut, and here it's easy. We know we have one layer of stents, not two. Inside that, we have that neoatheroma. All this is neoatheroma, all this is neoatheroma, and heavy calcium at the surface of that neoatheroma. And this is the underexpanded area. Keep in mind here we had already dilated it. Actually, we had dilated it with a 3 millimeter balloon before the IVUS. And despite that, it's only 5 millimeters square, so it's still underexpanded. Less than 5.5 millimeters square, and definitely way less than the distal reference lumen area, which was here around 7.5 millimeters square. So definitely way less than 80 to 90% of the distal reference lumen area. So after defining the mechanism, we will proceed with treatment, and we will ask ourselves the two questions: how to prep those lesions and what's the ultimate treatment. So how to prep? This is calcified neoatherosclerosis. How do we prep it? High pressure balloon, lithotripsy, cutting balloon, plus or minus laser or rota. That's the prep. Then the eventual treatment for neoatherosclerosis is DCB or DES. I will favor DCB as a first line option. For the underexpansion, it's high pressure balloon, lithotripsy, plus or minus laser or rota if those fail, but not restenting and not DCB. So DCB and restenting only for neoatherosclerosis. So the prep is kind of the same for calcified neoatherosclerosis and underexpansions. High pressure balloon, lithotripsy, plus or minus laser or rota. And I want to indicate here one issue we can encounter. When you're crossing so many stent layers in the left main and into the circumflex, if after wiring you have difficulty advancing a balloon, including a 2 millimeter balloon, that usually means that your wire has gone beneath the stent struts somewhere, whether in that left main stent, which was placed relatively recently in 2024, or maybe behind the stent struts of that underexpanded stent also placed in 2024. So if you encounter difficulty advancing a balloon, before attributing that to the tightness of the lesion or the calcification of the lesion, think maybe my wire is behind the stent struts and rewire. And that's what we did here. We encountered difficulty advancing a balloon. Instead of stepping up to laser or rota for balloon uncrossable lesion, the first reflex here, since I crossed so many stent layers, is to actually rewire. And this is how we rewire. The wire has to be free and densing at all the time. This is how you make sure the wire doesn't go behind the stent strut. It's densing and free. If you buckle at one point, you pull back, you make it dense and twirl and be free at all times. So watch again. It's coming out densing and free, twirling at all times. It buckles here, which means I want to go behind the struts. So I pull back, I twirl it and dense it again, and re-advance, twirling and dancing. And after I did that rewiring, dancing and free all the way, we were able to advance balloons very easily. And I stuck with that strategy of high pressure balloon and lithotripsy for both those areas. A high pressure 3 millimeter 24 atmosphere balloon did not allow that area of underexpansion to yield. So we use lithotripsy 3 millimeter for both areas. And after lithotripsy, I use a 3.5 millimeter non-compliant balloon for the underexpanded area, which yielded very easily after lithotripsy. It did not yield before, but it yielded very easily after lithotripsy. Then I did a drug-coated balloon therapy of that area of the stent, which is calcified neoatherosclerosis, after using lithotripsy and high-pressure balloon. And this is the final result. Keep in mind, this patient has a creatinine of 4. So we did the whole case with 7.5 milliliter of contrast, using a lot of IVUS and using the prior stents as roadmap for our wiring and ballooning. And this is the underexpanded area, how we improved it. It was 5 millimeter square after 3 millimeter high pressure balloon. It became about 6.5 millimeter square. Still not perfect, but much improved, certainly by Cine. And it was ranging now about 80% of the distal reference lumen area. And this is the calcified neoatheroma. This is the result after drug-coated balloon. It improved. Keep in mind, this image was obtained after 3 millimeter balloon. This is after lithotripsy and 3 millimeter drug-coated balloon. It improved to 9.4 millimeter square. And you can see that a lot of this calcium has been fractured and pushed with the vessel expansion.